how are you? My name is Dr. Anthony LaVacca, and thank you for listening to this audio and seeing our slide presentation. Currently, I reside in Chicago, originally from New York, and I kind of practice in the luxury of having multi-specialties around me. My wife and I have started a group where we have orthodontist, she's the orthodontist, prosthodontist, general dentist, endodontist come in. And what we've done in Naperville is develop this sort of office where patients can come and be served in one place. And what that does for me is it allows for us to practice care without having to refer patients to multiple different offices. Being in Chicago, originally from New York, a lot of people always ask me during this lecture, hey, is that you underneath the bean? After getting that question several times, I decided to dub my face in there. But what I really want to talk to you today about is something that always comes up with my larger cases is where is the vertical? Where is the vertical dimension, and how do you find that vertical dimension? And how do you find the vertical dimension, and what is going to be your final result at a certain vertical? And it seems that all of us struggle with this, and we use a lot of classic laboratory information, and we try to fit our patients into that mold all the time. But what I'd like to do during this presentation is give you some information that has been presented to me by Earl Pound, an article called Let S Be Your Guide, and use that classic literature to help all of us find where a true vertical dimension is and how that can relate to our full mouth rehabilitations, our implant rehabilitation, and then also these things can also help us out with our dentures, which is sort of really a lost art recently. And what we have here in Chicago and Naperville, Illinois, is an implant study club where a lot of doctors get together on a monthly basis to review some of the problems that we have during our practice and bring them out to the table so that all of us can get together and describe our complications that we had during the past week or past month and all get together and put our minds together to resolve them. So routinely when I start this presentation, I ask everybody, who here likes to treat full mouth rehabilitation? And, if you have an audience of 100, you'll see, 30, 40 hands go up. Then I lead into and I segue into, who likes to treat veneers? And oh my God, the whole entire audience's hand goes up. But then I throw a little curveball to them. I said, well, who really here likes to do dentures? And literally there's 4 or 5 hands out of an audience of 100 that go up. And it's really interesting that, no one really likes to do dentures anymore, but the foundation of principles for our full mouth rehabilitation and a lot of our cosmetics through veneers come from our basic principles of dentures. And sometimes the dentures are the hardest cases to do unless we have dental implants in place. Dentures not only allow for our patients who are edentulous to have teeth and smile and have a feeling that they are completely whole with their teeth, but dentures also need to be functional. And so do our full mouth rehabilitation and our veneer cases. Sometimes we're very caught up in the aesthetic component of teeth, but we sort of forget about the functional part. And one of those key functional parts is the vertical dimension. And when you're starting from nothing, meaning you have 2 edentulous arches, and maybe this case has been referred to you, the restorative doctor, by an oral surgeon or a periodontist, and someone comes in with some dentures and their face looks terrible, we need solid starting points. And once again, those solid starting points come from our denture principles. And with those solid denture principles, we can take a patient who comes into us with significant advanced periodontal disease, as demonstrated in the left-hand side of this slide, and we can bring them back to their youthful appearance, as demonstrated in the right-hand side of the slide, by providing them with proper facial aesthetics, along with tooth position to give them a harmonious smile with their face. And then within there, all of this has to be built within the boundaries of their vertical dimension. When I'm doing large implant reconstructive cases, the question always becomes, well, how do you do that? Do you do that on 5 implants, 10 implants? And it really doesn't matter the number of implants. It's actually the positioning in a vertical dimension on which abutments you are to select to maintain resistance and retention form of your prosthesis. So if we are replacing hard and soft tissue on a number of implants, it's critical to understand where the vertical dimension is and how to find that position, because that is going to be one of the beginning starting points of developing our aesthetics, of developing our function, of developing and allowing our patients to eat and chew properly. Because when this vertical component closes, that's what's going to give us their ability to chew and eat their food. Now, within that realm, we need to be able to speak properly and smile with a smile that is attractive and complements the patient's face, their facial characteristics. But as one over time has lost a significant amount of bone, one of our concerns of things that are lost within the vertical component is gingival tissue and the alveolus. So if we are replacing the gingival tissue, the alveolus, and the teeth, it's critical to know where this position is when we're designing our substructure to allow for us to bake porcelain, to have a tooth look, along with gingival component to give the replacement of hard and soft tissue. And these cases become significantly expensive in the laboratory if we don't have that vertical properly set along with the tooth position properly set. So what does it matter? Well, once again, the vertical component, as demonstrated in this slide, will allow for us to make our teeth within the muscular component and within the patient's physiologic component of their musculature, of their lip support, of their speech, and that will give us a final result that is proper in aesthetics, cosmetics, and function. And once again, taking a look at our patient here, he demonstrates a lot of basic denture principles. We have the mandibular arch bisecting the corners of the mouth. We have a smile line that follows the lower lip. And if you can hear him speak and function, we would be able to demonstrate to you how their siblet sounds function within the arena of their maxillary and mandibular rehabilitation. We would know that their fricative sounds are something we're going to utilize to establish maxillary anterior tooth length. But once again, all of these need to function within the muscular realm of our patient so that we can come up with a successful result. So now let's take a look at real life. If we were looking at real life and we had our patient, we're going to have a midline which properly divides the midface through the center of the nose, through the center of the. We would look at the interpupillary. The eyes would be parallel, would be even to each other, drawn on a horizontal line, and then the facial third would be broken up into even thirds. Now let's look at real life. We have our patient who has her interpupillary line is even, and if we looked at her face in a vertical method, you would see that her face is divided in equal halves. But one of the things that really jumps out at me with our patient here is that her lower third is significantly larger than her middle third. And that gives her an appearance, as she states, as looking like a witch or looking very old. Now, what she really wants to do is she wants to look young again. She wants to look the way she did when she was 20-some-odd years old. And a lot of us have experienced that patient that comes into the office. When we look at our patient from a lateral view, you can really see that lower third is really exacerbated. And one of the things is with that lower third being exacerbated is if we take a closer look, with the closed vertical dimension, you'll notice a significant number of lines or wrinkles, and you would never want to tell a female that her lips look wrinkly, but in this case, this demonstrates a significant deepening with the overclosed vertical of the nasolabial fold, bilateral, along with several the wet dry line of the lower lip is actually inverted. And the reason this is because when we retract her lips, this is the prosthesis that she has under it. Now, with this denture followed traditional laboratory denture guidelines. Okay, you set the teeth over the ridge on the lower, you set the teeth over the ridge on the maxillary arch, and this is the ideal way for a denture setup. Now, when a patient has had a denture for a significant number of years, we have a loss of bone in the maxilla and a loss of bone in the mandible. And thinking about this, wow, and a significant loss of vertical dimension or supposed loss of vertical dimension, we have to get back to our starting point. Now, why would we want to set teeth over the ridge after there has been a significant amount of bone loss? It really doesn't make sense, because if we're going to set those teeth over the ridge, I know we're supposed to be concerned about more bone loss, but what it does is it makes our patients look significantly old and significantly wrinkly. And with the loss of vertical dimension, you have deepening in the nasolabial folds. You have the lower third looking larger than the middle third. If we take a look at this panoramic view demonstrates her prior to implant placement. And notice, you can literally see how much bone loss she's had over the years. And how do I know she's had a significant amount of bone loss? We have the mental foramen bilateral sitting right up on the crest of the mandibular ridge. On the upper, very minimal bone left there. And her primary concern is, she really wants to have dental implants to look younger. So, we had several implants placed in the mandible. Now, why the mandible? Well, usually patients don't have much difficulty with the mandibular implants, because the mandibular denture that they had prior usually is very loose and moves around significantly. But with implants in the mandible, this allows for us to do a significant service to our patient, because now we'll be able to control her vertical by having it either clip on or screw retained, and it'll help us in bringing out our patient's aesthetics by having control and not letting the patient's musculature control the bottom denture. So with the prosthesis now anchored, we can now bring the teeth forward past the crest of the ridge on the mandible, which allows for us to bring our patient's maxillary teeth past the crest of the ridge, and that will give us a fuller look, a more aesthetic look, and have our patient smile with confidence. So our patient presented to an oral surgeon, had the implant placed with hope to look younger. And she wants to look like the slide prior. She wants to look as she did when she was back in her 20s or 30s. But with the way the initial dentures were constructed, quote unquote, over the ridge, no vertical dimension, loss of significant vertical dimension, it made her look old, and she was complaining that she was looking like a witch, and she is not happy, for sure. Now, I'm going to show you the final result that made her happy by me sitting down with her, speaking to her, developing a rapport with your patient to find out what their actual expectations are, having them bring pictures in and photographs of when they were younger, of how they looked, how their teeth looked. And the end result that really made her happy was to give her her smile back, fill her smile out, and make her look as if she was significantly younger. When I look at our patient here, one of the things I do see is a woman, an older woman who significantly takes care of herself. And how do I recognize that? Well, one, she goes to the beautician frequently. She has her hair done. She has her coloring is done all the way down to the roots. She manicures her eyebrows. But what's interesting about eyebrows is she manicures her eyebrows so that they are higher above her existing eyebrows and thinner, so it gives her eyes a broader and a brighter appearance and a more youthful appearance. She routinely does her eyes with mascara, and lip liner is another interesting thing that we can talk about, is that lip liner is especially important to women to increase the illusion that their lips are larger by taking their lip liner and going up over the border of their lips to give their lips a more fuller look. So when our patient presented to me, as demonstrated on the left-hand side of the slide, significantly unhappy with the way her denture was, she showed me pictures and demonstrated to me how she routinely looks and wants to look. So we were able to find where her vertical dimension was from slide 1 to slide 2. Work on aesthetics, tooth size, shape, and color from her pictures and from her diagnostic information, and then give her a smile back that she deserved and she wanted. So let me show you. What I did here was I made her denture, I transferred her denture information to the master cast, and one of the landmarks that we can use is the incisal papilla as an accurate landmark to measure where tooth position is. And if I took her old denture and measured her tooth position from the incisal papilla, we came up with about 9 millimeters from the incisal papilla to where her maxillary anterior facial portion of the tooth was. This is a very interesting slide. What I've demonstrated to you on the left-hand side is by utilizing the incisal papilla, I am able to measure from the distal aspect of the incisal papilla to the incisal edge of the old denture and demonstrate to you by measuring that tooth position is about 9 millimeters from the incisal papilla. The denture on the right now, if we took the position from the incisal papilla and measured it to where the maxillary anterior teeth are, we have about 12 to 13 millimeters. Now, what this does for our patient facially is that it will begin to reduce those wrinkles above on our maxillary lip. We'll be able to fill out those nasolabial folds slightly to give our patient a more youthful appearance. Now, once we couple that with the whole component to this lecture with the vertical dimension component, we're able to establish that vertical and maintain the mandibular denture in place by utilizing our implants. We are going to give our patient a functional, aesthetic, and give her the look that she desires and wants. Wow, vertical dimensions. So we're finally getting to the point of where the vertical dimension is and how do we find it. I mean, if we look at these two dentures side by side, you can literally see there's about 10 to 15 millimeters more on the left denture, which is our final denture, versus the denture on the right-hand side, which is the denture that she came in with. And with that denture, we have done some custom modification, and you can see the amount of soft and hard tissue being replaced with our denture acrylic to give us that increased vertical dimension. But how do you know where it is? Let's take a look at where our starting point is. If I measured her vertical dimension with her existing dentures in place and using a tongue depressor, making 2 marks on it with the patient with some marks on her face. And then now you're going to look at me and say, wow, this is really, I can't believe you opened the vertical dimension in that much. And then measured it with the marking stick with the new denture in place. You can see what I have done here is I've actually opened the vertical dimension a full centimeter. Now, this is where we get into why this classic article is so important. And what I want to drive home to you and give you the key pearls to where is that vertical dimension and how do we find it is it's just a great article written by Earl Pound. What Earl Pound considers to be a great vertical dimension starting point is to use a sound, or as in the title of his article, let S be your guide. Let S be your guide will give you the information that you need to find a vertical component by using the siblet sound or the S sound. When you say S, a number of things happen. When you say with the S sound, the lateral borders of your tongue will go up and touch the inner aspect of the premolars. S. As that touches the inner aspect of the premolars, the tongue then forms a groove. With the tongue forming a groove, the air is expelled, S, and that S sound goes over the maxillary central incisors and through the mandibular lower incisors. So with the sound S, you're getting a lot of information. And it's pretty interesting that we always say, well, say Mississippi, and there is a component to that, which is one of Earl Pound's guides, the siblet sound, is that S sound will give you something called the closest speaking space. The closest speaking space is where the mandibular plane and the maxillary plane are as close as it possibly can be to allow for your restoration, your full mouth rehabilitation, your dentures to function in the closest spot that it can function within the patient's muscular realm. So, when you say S, the mandibular teeth are approximately 1 millimeter from the maxillary posterior teeth. So, with the siblet sound or the S sound, this is your guide for vertical dimension. Now, with the siblet sound, once again, we spoke about how the tongue braces against the premolars to say S, and you can feel that. What that'll do is that S and the lateral border of your tongue will give you your maxillary posterior tooth position by allowing it to fill out your buccal space. If the maxillary arch is too constricted, your patient may say S and come up with a shushy type of sound. And it also is very difficult for them to eat and chew and also speak, because when they speak, they find that their tongue is getting stuck on the premolar teeth. So the S sound has to be a function of a vertical component, which is the closest speaking space by Earl Pound, a horizontal component by allowing the tongue to fit into where the teeth should be, and also a functional S sound. The maxillary anterior teeth and mandibular anterior teeth need to be positioned in approximately 1 millimeter vertical and 1 millimeter horizontal overjet, so that the S sound, the air is expelled over those teeth to give the patient an S sound that makes them sound like they are whole. So look at this. I mean, if we look at that tongue blade, once again, that's about a complete centimeter. And then you go into the whole mystery of, well, how did you open them up that much in that quick of frame time? And I say, well, I really didn't open them up that much. To me, this patient has been over-closed for too long of a period of time. And by me fabricating my new prosthesis, utilizing SB or Guide, that really just restored her to where her original position is. With that original position, I really truly didn't open the vertical. I just found the proper position for her vertical dimension that was within the functional guidelines of her speech, which is in the functional guide for her to eat, and provided her with the aesthetics she wanted. Let's take a look at what it does to our patient. Let's take a look at what it does to her face. Let's take a look at how it's improved her look and how it satisfied her expectations of what she wanted through implant rehabilitation. Taking a look at a lateral view again, we can see that loss of the two photos on the left demonstrate a loss of vertical dimension. Once again, increased nasolabial folds, a long lower third. Now, opened up a full centimeter. Look at what happens. Beautiful. We have increased her middle third, and we've actually brought her middle third out to be almost parallel with her chin. We have inverted her lip her lip is slightly rolled out now to give her an appearance of youthfulness. Her lower third now has not really changed much. We've done all of the adjustments in the maxillary third, but with that increase of vertical dimension, notice her chin point. Because going back, when you open someone's vertical dimension on the arc of closure will allow for the mandible to swing posterior. So as you increase her vertical dimension, the mandible will drop down, and on the arc of closure, it will bring the chin back automatically. And that's what's created our patient to give her a smile. And if we look at the red line on the facial, completely demonstrates how she looked without her denture, with her old dentures. And now if we drew the same line, we have pretty much a vertical appearance, and it gives her the facial aesthetics that she so wanted and so desired. But with all that said, there's a big negative here too, which I just found out. And that is, with the increase of vertical dimension, one of the things you do lose is you develop, as the mandible swings downward, you develop something called a turkey neck. Not necessarily a very good term through plastic surgery, but the tissue underneath her chin, as you increase the vertical, will begin to bunch up. And believe it or not, she is a very conscious person of the way she looks. She spoke to me about this, and I said, well, you know what? There's nothing I can do about that. You need to see your plastic surgeon. So let's recap. Taking a look at her existing denture with an overclosed vertical, teeth set over the ridge, provided her with an older appearance, something that she was not looking for when she had implants. She thought implants would give her a more youthful appearance. With the new denture fabricated, we were able to give her the tooth size and shape she wanted. We were able to bring the maxillary anterior teeth forward from the ridge approximately 15 millimeters by the incisal papilla. We utilized Earl Pound, let S be your guide, to develop and find where the vertical should be through her siblet sounds. And that allowed for us to develop the buccal corridor because our premolars were in the right position. So our siblet sounds were fabricated through Let S Be Your Guide, Earl Pound, 1 millimeter vertical and horizontal overjet of the maxillary mandibular anterior teeth, and gave our patient the look that she wanted. So if we take that tooth position and we look at where she wanted to be using the cosmetic guidelines and looking at her where her existing denture was, and then her final with her lips together, you can notice there's a decrease in that nasolabial fold. She looks great. She has her lipstick on. And now our patient is happy. And now we have met our patient's expectation through dental implants and gave her the smile that she deserves, wants, and now she is your biggest sales point out there. Because, yes, she does have a very large social life for a wonderful, wonderful woman. Thank you so much for listening to this educational program. If you have any questions regarding vertical dimension or Let S Be Your Guide, please do not hesitate to contact me, Anthony LaVacca, at LaVacca@me.com.